Chapter 27, Part 1, Face and Neck Injuries. The face, the head, the neck, very vulnerable to injury, especially given the fact that it is a target. It's a big bowling ball on top of a toothpick. Lots of blood supply, so often those injuries are going to be life-threatening, and we will talk about treatment and recognition of those injuries. When we have quality patient care, quality pre-hospital care, and quick transport, the patient can actually have a very good outcome from what would originally be viewed as a devastating injury. So let's look at the anatomy of these structures. The head starts as the cranium. It's where the brain is, so obviously it's a very important part of the anatomy. Also referred to as the skull, and the brain and the spinal cord connect at the foramen magnum, which is at the base of the skull. So not only does the skull protect the brain, but it also protects that connection between the brain and the spinal cord. The very far posterior, so rear portion of the brain is the occiput. And then you've got the temples or temporal region on both the right and the left side. The forehead is called the frontal region, kind of makes sense. And then anterior, kind of right to the ear, in the temporal region, you can actually feel that temporal artery. Right above the ear, kind of right around the ear, you'll feel where the temporal artery flows. The face. When we think about the face, we know it's the eyes, ears, nose, mouth, and cheeks. The face has 6 major bones. The nasal bone, which ends and then is met with cartilage. 2 zygoma, or cheekbones, that come kind of off the nasal bone. 2 maxilla, the right and the left upper jaw, and then a single mandible. The orbit of the eye, where the eyeball sits, is made up of multiple parts of different bones. So the orbit is actually composed of the frontal bone, the zygoma, both right and left, obviously, right and left maxilla, and the nasal bone. So think about that. Your upper jaw bone creates part of the orbit. And this is designed to protect the eye from injury. Your eyeball sits slightly back into the orbit so that that part of the frontal bone and the part of the zygoma provide a little protection. The proximal third of the nose is formed by the bone. So that top part of the nose is bone, the rest is all cartilage. And then we've got the side where you've got the exposed portion of the ear that is soft tissue covering cartilage. And you've got the pinna, the tragus, and the superficial temporal artery, which you can see here. And the ear is going to sit just behind the TMJ, the temporomandibular joint. About 1 inch posterior is the mastoid process. The mandible forms the jaw and the chin. So as you feel basically just in front of the ear all the way down and around your face, you will feel all of the mandible. It is the lower border of the mouth, and the tongue and the 32 teeth are located here. Motion of the mandible at the joint is relying on that joint. So if there's issues near the ear with that joint or near those bones, the jaw likely will not function appropriately. The neck obviously contains multiple important structures. The neck, supported by the cervical spine, so C1 through C7. Another reason why we want those to be well protected. The esophagus and the trachea run midline into the neck with the carotid arteries on both the right and the left side. Here you see the cartilage and the arteries, so the thyroid cartilage, as well as the muscular structures within the neck. The Adam's apple is located center and anterior, so midline and towards the front of the neck. And you can see the cricoid membrane and the cricoid cartilage, as well as how the trachea run through the neck as well. This has removed the muscles, showing you where the larynx sits and how the cricothyroid membrane lies between the thyroid and the cricoid cartilage. That is a thin sheet of connective tissue that joins those two cartilages together and often feels like a soft depression midline in the neck. All right, then we move to the eye. The eye, of course, sits in the orbit. It's what we see with. It is a globe shape, approximately 1 inch in diameter. It does sit recessed into the orbit. And the orbit protects about 80% of the eye, so we definitely like when all of those bones are appropriately functioning. Here you see a cross-section of the eye and shows you the major components. There is blood flow going to the eye through the artery and nutrients delivered that way, and then the waste is sent through the vein. Remember that you've got the lens, the pupil, the cornea, and the iris. The pupil, of course, is what constricts and retracts, constricts and dilates so that the appropriate amount of light is being sent into the eye. You can see the optic nerve runs with the artery and the vein, and then most of the compartment in the back is filled with a vitreous humor, so a thick fluid. And it is a jelly-like fluid. It can, unfortunately, if there is a leak, that aqueous humor, which sits in front of the lens, can actually leak out. So, of course, we've got to be very cautious and concerned when we have penetrating injuries to the eye. So the conjunctiva is that membrane that covers the eye and maintaining its moisture. If you've ever had conjunctivitis, that's where that infection is. Then you've got the lacrimal gland that sits just above the eye that actually produces the fluid that keeps the eyes moist. You've got the nasolacrimal duct there. And the two of those work together to help clean the eye. So as the lacrimal gland produces the fluid, it will flow into the nasolacrimal duct to be removed. The sclera is the white tissue that maintains the globular shape. As it moves to the front of the eye, the sclera gets a transparent clear membrane called the cornea. Cornea lets the light enter the eye. The iris is the muscle behind the cornea. The iris is what is pigmented to give the eye its color. The iris is the muscle that changes the size of the pupil to allow, and the cornea to allow appropriate light to enter the eye. The pupil is what allows the light to get to the back of the eye, and it ensures that you are processing sight. We are worried, of course, about unequal pupil size because it can be a sign of a head injury. But there are disorders where people end up having unequal pupil sizes, either from birth or due to a traumatic injury. The lens lies behind the iris, and that's what focuses the images to the back of the globe. The retina is what contains the nerve endings that process the light transmission and send messages to the brain. Those messages get sent through the optic nerve. When someone suffers from retinal detachment, what's happened is that the retina has disconnected from the vessels and from the sclera. And retinal detachment causes blindness and can happen in traumatic injury. When we have injuries to the face and the neck, we're looking at a possibility of partial or complete upper airway obstruction, because if you've damaged the teeth, you've damaged the jaw, the tongue and the teeth, and the bleeding become a concern. We, of course, have issues associated with very heavy bleeding in the face and in the head, because it does have a lot of blood flow. So blood clots can form when we have heavy facial bleeding. Direct injuries, dislodgement of teeth and dentures or braces, whatever's in the mouth, can become an upper airway obstruction in a significant trauma. We also have to be concerned about the swelling that can occur. Swelling can impact the airway. So if I have broken my nose, the swelling of the nasal passages alone could cause issues with taking air in. We've got possible injuries to the brain or the cervical spine that can impact our ability to actually take a breath, to get the messages that we need to breathe. So we see a potential increase in altered mental status from that lack of airway and inefficient and insufficient airflow. Soft tissue injuries to the head and to the neck are very common. It is very vascular, so we see an increased likelihood of bleeding occurring with these injuries. In the older patients, because the skin is thinner, you do see a significant likelihood of head trauma and with significant bleeding. Blunt injuries can cause hematomas, or avulsions can occur based on the type of traumatic injury that they face. So because there is such a rich blood supply to the head and the neck, you do have to be cautious of assuming that it's a significant bleed. It can bleed profusely. So it can be instead of significant bleed, you have to be cautious it's a significant injury. Minor injuries and head wounds and neck wounds can actually cause significant bleeding. When we're talking about the face and the mouth, dental injuries are very, very common. And that's not just injuries to the teeth, but injuries to the structures of the mouth. So fractured mandibles, fractured maxilla, teeth that have been knocked out, issues with all of that. Most of them are the result of assaults or motor vehicle crashes. So your general fall isn't necessarily going to cause fractures and dental injuries. How do we know there's a mandible fracture? So if you go to do a jaw thrust and you go to the angle of the jaw to push up and it's more jello, or you feel bones rubbing together, that's probably a really good sign that your patient has a mandible fracture. Also, if the teeth are misaligned, or they have numbness in the chin, or they have the inability to open their mouth, or when they do so, there's significant pain. It doesn't actually have to be a full fracture. It could just be a crack in the mandible that is causing the problems. Also remember, if it is, a crushing fracture to the mandible, not just the teeth, but the tongue become concerning. The mandible provides the structure of the mouth and maintains the tongue in place. So, we've got to be concerned with dental injuries that there will be airway issues. Maxillary fractures are usually found with blunt force high injury impacts. Again, assaults, baseball to the face, motor vehicle crashes, and you do see the instability in the facial bones. Remember, the maxilla make part of the orbit, misalignment of the teeth, and significant facial swelling all can be common. And because that upper airway, that upper jaw sits just below the nose, swelling in a maxilla fracture can actually cause airway issues as well from the nose, not just from the mouth. If teeth have been removed, cracked, broken, avulsed, if they can be removed, you should remove them to make sure that those teeth segments don't go into the airway. So when we have these injuries, we're going to assess, and because it's the head and the face and the neck, it's pretty easy to see, because as we approach our patient, we're normally making eye contact, so you should immediately see some of these. But again, don't get tunnel vision. We need to start with Scene Safe and BSI. Am I safe? Do they have protective equipment that is appropriate? If I'm looking at somebody who has an upper airway, a mouth, a nose issue, if they start coughing, if they start having issues breathing, there is a higher chance of blood or other bodily fluids. So like, sputum, etc. So I'm probably going to want eye protection and face mask. We're going to determine the number of patients. We're going to assure that we are safe and our providers are safe as well. I'm going to consider the mechanism of injury. I'll get some of this from the dispatch, but also from the scene. Some of the common calls we get that we see are facial trauma and our neck trauma, motor vehicle crashes, sport injuries, falls, penetrating traumas, so shootings, stabbings, etc., and blunt trauma. We're going to move on to our primary assessment. Also, in our initial assessment, our scene size up, we're going to have called for assistance if we need it. We're going to focus on, as part of our primary, we're going to focus on identifying those life threats. Is the bleeding significant enough that I need to stop what I'm doing and do CAB instead of ABC? I'm going to, consider whether there are immediate threats that should be addressed before I go to airway and breathing. For the most part, especially with face injuries, those immediate threats may actually be both bleeding and airway if they are bleeding into their airway. Getting that general impression, do I see all of the injuries? Do I believe that my patient needs manual stabilization and take it? What's the seriousness of my patient's condition based on the clues that I am getting when I walk up to the scene? I'm going to check for responsiveness and conduct AVPU as well. So once we've done all that, we can move to our airway and breathing. We need to, of course, ensure that the airway is open and clear. If there are facial wounds that are causing bleeding into the airway, we may be suctioning for a significant period of time. Now, that doesn't mean constant suction. Remember, when you suction, it is for no greater than 15 seconds while removing the suction catheter. Always consider whether you need to use a properly sized oral airway or if a nasal is appropriate. However, if it's head trauma causing nosebleeds, do not put a nasal airway in. Assess for the adequacy of breathing. Is there equal rise and fall of the chest? If there has been head and neck trauma, was there trauma somewhere else? So let's palpate the chest to see if we have any issues with broken ribs that are going to impact the quality of breathing. At this point, we don't necessarily want to restrict the chest wall and take care of things. If breathing's adequate, put them on 15 liters non-rebreather. Do you need to ventilate your patient? All of this is considered during breathing. Then we move on to circulation. If there is bleeding that we haven't already controlled, let's do it now. Let's do a quick head to toe for immediate bleed check. Check our capillary refill, look at skin color, temperature, and condition, and assess pulse rate and quality. Is it strong, rapid, weak, thready? Do you have radial and carotid or just carotid? Once we've done our ABCs, we move to a transport decision. Is this patient a high priority? And if they've got issues with the airway and bleeding into the airway or issues with breathing, then we probably need to go ahead and treat them as a high priority. If they've got a neck wound that's hard to control, they're a high priority. Obviously, as we've said during our bleeding chapter, if it's internal bleeding, we got to transport them quickly because of the fact that this is, or a head injury that is causing bleeding from the ears or nose. Those are high priority patients. So at this point, let's pack them up. Let's get them into the back of the truck. Remember that our patient in shock is a high priority patient. And those signs and symptoms of shock are tachycardia, so high heart rate, tachypnea, high respiratory rate, low blood pressure, weak pulse, and pale, cool, clammy skin. So shocky patients should be a high priority. However, that doesn't necessarily mean that they're going to show the signs and symptoms of shock initially. It may take time. Because of the force that it takes to cause injury to the skull, to cause skull fractures, if your patient has skull fractures, if your patient has a significant blow to the throat and to the face, to the head, then you probably want to maintain a high suspicion of brain injury and you want to transport them as a high priority. If it's an eye injury, we definitely want to get them to the hospital quickly because 30 minutes or less is our goal for them to get definitive care, because greater than 30 minutes may cause blindness if they can't get treatment in time. Going to look at the history taking and am I asking the right questions? Obviously, we need to be alert to the situation, to the mechanism of injury. We need to be aware of those pertinent negatives. So it's a good thing to not have certain things. So if there's no trauma noted, no DCAP BTLS noted, that's a positive thing. Doesn't mean they don't have an injury, but at least externally you're not seeing anything. Our sample history, of course, if our patient's unconscious, we try to gather it from a crowd, from anyone around, looking for medical alert bracelets and other things. When we get into our secondary assessment, which in our high priority patients should be done in the truck, we can start on the physical examination. If they are responsive patients, so it's an assault and they're still conscious, but they've, bloody nose, swollen face, etc., then we can focus on the impacted region. But with head injuries, of course, the brain could be damaged. So if you have the opportunity, go ahead and do a head-to-toe full DCAP BTLS check. Go ahead and check all of the body, especially if you're concerned there might be things they're not telling you about. A head-to-toe DCAP BTLS check when you have time is not a bad thing, even in a conscious and responsive patient. Of course, you note injury locations, treat them as you can, inspecting open wounds, stabilizing impaled objects, treat the injuries at this point. Use your hands and your eyes. Our DCAP BTLS head-to-toe assessment is about using our hands to feel and also looking as well. When we are looking at the eyes, we want to start on the outer aspect. So as you palpate the eyes, you want to do so around the outer aspect and move into the center, working towards the pupils as well as you look. We're looking at the eyes for any foreign matter. We're trying to see, can they see? Can they move their eye? Is there any discoloration, redness? Does the bright lights hurt using the pen light? Are the pupils responsive? Understand that if the patient has glaucoma, if they're blind, if they've already have a history of nerve disease or eye issues, the pupils may not respond anyways or may already have an inappropriate response. So you can't always necessarily use the pupil response to determine whether or not the eye has been impacted. We get our vital signs, always get that baseline vital signs. Make sure that you're using any monitoring devices appropriately. Make sure that you're assessing the pulse in the neck and the radial pulse, just to make sure, especially in neck injuries, that there are no issues with circulation. that the pulse and the radius and the pulse and the neck match in terms of strength and beats. We do the same reassessment. We're rechecking our primary assessment, our ABCs. We're making sure that the chief complaints are still their chief complaints. Checking the vital signs, making sure all of our interventions are appropriate, making sure that any bleeds are still controlled, that the airway is still being maintained, etc. Our reassessment is the same no matter what in terms of what we're doing. It's just different in terms of what we have to check. So we're going to take care of that every 5 minutes, especially with those head wounds, given the potential that brain injuries can show later on. We're going to make sure any of our interventions are appropriate, control those significant bleeds, suction, bag valve mask, move from oxygen to a bag valve mask if necessary. Insert an oral airway at any point that the airway becomes unsecure, not just at the start of the call, but at any point. So you might have to check the airway insertion at this point. Treat any signs of shock, so cover them with a blanket, be hesitant to put them in Trendelenburg with these patients, given the fact that they could have a head injury and you don't want to force additional blood into the head if that's what they're dealing with. So oxygen and preventing any heat loss will be important here too. Reassessment also includes communication and documentation, recognizing and reporting both in writing and in your hospital report the injuries, the response to treatment, and any changes that have happened as you are transporting the patient.